Dr. Mamoona would be accompanied by Dr. Hazim Brohi, who's an associate professor of neurology at Liaquat National Hospital in Karachi. So the first session, the first topic of the second session is Etiology and Pathogenesis of Parkinson's Disease by Dr. Aziz Sonawalla. Dr. Aziz Sonawalla is a senior lecturer in neurology in the Aga Khan University and is honorary professor of neurology at Ziauddin Medical University, Karachi, and is the president of Pakistan Headache Society. So now I'd like to welcome Dr. Aziz Sonawalla.
Bismillahirrahmanirrahim. Assalamu alaikum, everyone. At the outset, I'm very thankful to the organizers for having invited me for this talk. And truly, this is one activity which is a very stimulating one, and I'm actually really thankful to the outside participants who have come here. And I'm told that the first session of the day was very interesting and very stimulating, which I missed, thanks to PIA. But I hope that the subsequent sessions would give you some food for thought. After the initial, agar pehla khana bahut hi acha hota hai, to the other ones become a little fika, but it would be our effort to make it as interesting. Well, the topic is, etiology and pathogenesis of Parkinson's disease. Truly, if you were to really sum up the whole thing in one sentence, then the etiology of Parkinson's disease is not known. Okay, you can stop at that. But the last 2 or 3 decades have seen a phenomenal progress in what we have understood as to how the disease proceeds. And maybe some of it can throw light into, some kinds of modes of treatment for this disease that is debilitating. We will skip the initial slides. We all know all the, and these are the clinical symptoms, the motor and the non-motor. We always focused on the motor, but we know that the non-motor symptoms are as important as the motor symptoms as far as morbidity is concerned and as far as, activities of daily living are concerned. We know about the pathology. Basically, the main problem lies at the level of the basal ganglia, mainly the substantia nigra, but other areas of the basal ganglia as well as the cortex, as well as the other areas of the brain. And the main pathology that you see are the Lewy bodies, which are present in large amounts in patients with Parkinson's disease, especially at the level of the substantia nigra as well as the corpus striatum. This is the appearance of Lewy bodies. Basically, they contain alpha-synuclein and inclusion bodies, and the significance of Lewy bodies is not known. Lewy bodies are also seen in other degenerative disorders involving the extrapyramidal system, Alzheimer's disease, and also seen in normals up to a certain extent. They are supposed to be associated with a degenerative process, although there were some interesting papers that I came across to suggest that they might actually be playing a protective role, and in the attempt to protect the brain, I think these bodies are formed, which are overcome by the actual pathological process, but we really don't know. Now, one more thing about Parkinson's disease, and I think the interesting presentations of the morning might have covered some of these things up, but Parkinson's disease, as we understand, is not just a movement disorder. It's a all brain process that actually starts way ahead before the movement disorder sets in. And Bragg's hypothesis suggests that the actual Parkinson process starts at the level of the medulla and the olfactory bulb, years before the disease becomes clinically manifest. In fact, the first changes are seen in the mesenteric plexus of the intestines. The first changes have been seen over there. And then the subsequent changes start at the level of the brainstem and the olfactory bulb. That's why anosmia is a common preclinical symptom of Parkinson's disease. And then the disorder proceeds up and then to the pons, and when the disorder comes at the level of the midbrain as well as the corpus striatum, the basal ganglia, it is then that the clinical features of Parkinson's disease comes into the fore. According to Brack's hypothesis, stage 1 and 2 are preclinical, stage 3 and 4 are clinical at the level of the extrapyramidal system, and stages 5 and 6 are the stages where the disorder proceeds up to the frontal lobes, the limbic system, the neocortex and all. So Parkinson's disease actually starts here in the medulla oblongata and the olfactory bulb, to some extent in the mesenteric plexus, and then slowly ascends, becomes clinical, as we know, when the basal ganglia are involved. So this is Brack's hypothesis, and this is how the nature of the disease seems to behave. So Parkinson's disease is not just basal ganglia, it is much more than that. This is a complex diagram, and I think Danish must have covered it up. So if he has covered it up, I think I'll skip because I cannot. Is Danish here? Yeah, he's been an excellent speaker, and we have to learn a lot, from our guests. Basically, this is just a circuit to show the basal ganglia in relation to the cortex and the putamen and the basal ganglia. Here it is normal. Here it shows all the circuits in perfect order, where you have the blue lines as excitatory and the black lines as inhibitory. So basically, these are all in equilibrium, and this is the corpus striatum, which has an indirect pathway along the globus pallidus, substantia nigra to the thalamus, and then there is a direct pathway from D1 receptors. So there are two kinds of receptors, D2 and D1. D2 work by the indirect pathway, inhibitory, and D1 are excitatory, and these work through the direct pathway to stimulate the thalamus eventually. And when these are in equilibrium, this is how the whole thing comes. The stimuli are sent eventually, the motor stimuli are sent to the thalamus with a certain amount of control, excitation and inhibition to produce the normal movements. The thalamus sends signals to the cortex, and the cortex produces movements. In Parkinson's disease, this is what happens. The substantia nigra is diseased. When the substantia nigra is diseased, both the D2, that's the inhibitory, as well as the D1, both of these are inhibited. And that leads to a number of processes that upset the equilibrium. There is an increase in inhibitory activity of the indirect pathway, and there is reduction of the activity along the direct pathways. The subthalamic nucleus is an inhibitory nucleus that sends excitatory signals. Now when this is further inhibited, the sum total of all of this results in greater inhibition of the signals to the thalamus from the corpus striatum, the globus pallidus, as well as the substantia nigra pars reticulata. So this is what happens. There is increased inhibition to the thalamus. The thalamus sends less signals to the cortex, and the cortex sends less signals to the brainstem and spinal cord, resulting in reduced movements. So this is the circuitry of the extrapyramidal system in connection to the rest of the brain in normals as well as in patients with Parkinson's disease. So this is basically what happens in patients with Parkinson's disease circuit-wise. Parkinson's disease can be classified as a synucleinopathy because along with other diseases like dementia with Lewy bodies, as well as Alzheimer's disease, as well as MSA, there is an abnormal accumulation of synuclein. Alpha-synuclein is actually a normal protein found in all cells in the body, especially at the nerve terminals in the CNS. We don't know the physiological function, but they probably play a role in membrane stability. In Parkinson's disease, there is misfolding of the alpha-synuclein. How it happens is probably because of an interplay of but when this happens, it leads to its abnormal accumulation in the cells, and this is the major component of Lewy bodies. So Parkinson's disease can be classified as a synucleinopathy, although there are other proteins also that are involved. So, like I said, we don't know what causes Parkinson's disease. The exact etiology is not known, but what we know is that there is most likely an interplay of a number of environmental as well as genetic factors along with the aging process. The male sex is more prone to Parkinson's disease, and a combination of this probably leads to clinical Parkinson's disease, as seen in animals, as seen in other experiments, as well as in observations. So this is probably what's happening. Now, there are certain risk factors of Parkinson's disease, and the risk factors with high correlation are family history, depression, and pesticides. It has been shown that those who have family history of Parkinson's disease would be probably 2 to 2.3 times more likely to have Parkinson's disease. Depression has been associated with Parkinson's disease with a high degree of correlation. I was not able to find the exact link between the two, but epidemiologically there appears to be a risk. The most important thing that has been studied is pesticides, and pesticides seem to be playing a definite role in the genesis of Parkinson's disease in humans also, certainly proved in animals. Then there are certain factors with possible correlation. We've heard about these, and maybe, yeah, they are correlated, but we are not absolutely sure about these. Head trauma. We know that head trauma, leads to something like punch-drunk syndrome, but whether they have a role in Parkinson's disease, well, is debatable. Low levels of vitamin D. Now, vitamin D has become fashionable, and everything seems to be caused as a result of lack of vitamin D. But this is an important link, and maybe that's, the case. Living in industrialized areas with high release of, these toxic metals also could be related. In fact, there was a paper that showed a belt, in the United States, I don't know where exactly, where people staying in that belt had a higher level of Parkinson's disease as compared to people not staying in that, And that had to do with toxic metals as well as pesticides. Farming, agriculture work, use of well water, excess body weight, these are factors with a possible correlation, whereas these factors have a high correlation, family history, depression, as well as pesticides. Now, neurotoxins certainly play an important role in Parkinson's disease. My slide is slightly... Okay. The first neurotoxin that was seen as part of Parkinson's disease was MTP that we all know. In 1980, it was shown that a number of these heroin addicts who took heroin developed Parkinson's disease, clinical features very like Parkinson's disease. And it was found that there was a toxin called MPTP. So the heroin was mixed with toxin, and the toxin was MPTP. When that toxin was isolated and it was, animals were subjected to MPTP, they developed all clinical features of Parkinson's disease. This was in the 1980s. It is metabolized into MPP, I don't know the exact full name, and it inhibits mitochondrial enzyme, and it causes dopaminergic cell death and Parkinsonism in experimental animals. So MPTP formed actually, for the first time, a basis to create an animal model of Parkinson's disease. So MPTP is definitely, a neurotoxin, but fortunately, I think it's not something that's easily available or not something that the environment is exposed to. More important than MPTP is pesticides. And a definite correlation has been seen with pesticides and Parkinson's disease in experiments. This pesticide, rotenone, it's a natural toxin. It selectively inhibits, again, the same mitochondrial OX-phos complex system, and a chronic administration of this causes selective degeneration of dopaminergic neurons and Parkinsonism in experimental animals. This is a paper that suggests this. Chronic systemic pesticide exposure reproduces features of Parkinson's disease. And this was an experiment on rats, and they were exposed to this pesticide over a period of time, and at autopsies it was shown that the clinical features in these resembled Parkinson's disease, and the autopsy studies showed that they had changes that you see exactly like in Parkinson's disease, including cell death, including inflammation, including progression, and everything. So these results indicate that chronic exposure to a common pesticide can reproduce anatomical, neurochemical, behavioral, and neuropathological features of Parkinson's disease. How would it correlate to humans? I mean, definitely, I mean, there would be something, and we have to be really scared of it, because I think, you know, organophosphorus and these compounds are freely used in the days of dengue and malaria and so on. I think no one sleeps without spraying, you know, these pesticides. What impact it's going to have in future is something that we don't know at the moment. So this is something that is of importance to everyone, but in a population that is chronically exposed, it's even probably more important. Certain interesting protective factors. If you're a smoker, your chances of getting Parkinson's disease are low. Should you smoke for that? Well, we don't know why it happens. Probably nicotine has a protective effect. Or some people have suggested that, you know, patients of Parkinson's disease, unki jo personality hoti are so, you know, akinetic that they don't really lean towards smoking, but we don't know. It could be a protective effect, but it is there. Similarly, you know, coffee and caffeine intake work by adenosine antagonistic activity, but we don't know. But they also seem to be having some protective effect. NSAIDs, again, query, and there is an inflammatory process which we'll come to in Parkinson's disease. And maybe that's suppressing the inflammatory process, maybe it's protective. And this is something that has been proven, moderate to vigorous physical activity. That's why in Parkinson's disease also, exercises now is an important factor, is a mandatory kind of treatment for Parkinson's disease. So exercises have a protective effect. Then we come to genetics. And a lot of work has been done in the last 20 years. But something more important than that, which I mentioned earlier, 20 to 25% of patients of Parkinson's disease have at least one first-degree relative with Parkinson's disease. And a large case-control study, this was 1996, found that first-degree relatives of Parkinson's disease patients are 2.3 times more likely to develop Parkinson's disease as compared to controls. And new studies have shown that there are certain genes, like PARK2 gene, you know, that are found at a higher association in patients, you know, who have what we call idiopathic Parkinson's disease in the adult, but yet they could be having a genetic component. So genetics is important. Now, a number of genes have been isolated, and the number is, and more are being isolated. So I'll just go through, you know, some of the ones that are generally talked about. So you have, you know, a Parkinson's gene PARK1, PARK4, and PARK8 over here. These are autosomal dominant. And the thing is that the younger the age of the patient, the more is the likelihood that this patient is having a familial kind of Parkinson's disease that is genetically mediated. And autosomal dominant is PARK1, PARK2, and PARK8. And PARK5. And then the others are autosomal recessive, especially PARK2 having the Parkin gene. This SNCA gene is the alpha-synuclein gene. And these are recessive. Autosomal recessive Parkinson's disease generally have a slower progression, but they are again seen at a younger age. So a lot of these, and it's, you know, I mean, now you have these PARK10 and PARK11 and others, and more of these genes are being isolated. So possibly the future of Parkinson's disease study may have a lot to do with genetics. The same thing. Now, there was a recent Genome-Wide Association study, GWAS, and this was in 2011, a study of all genes and all associations, and it was found that there was an increased correlation with alpha-synuclein PARK1 gene, LRK2 PARK8 gene, as well as another gene, that's what we call the Gaucher's gene, you know, in the genesis of Parkinson's disease. So patients of Parkinson's disease would have a more likelihood of having some of these. So again, genetics becomes important. Now, those patients whose family members have had Gaucher's disease and they are carriers of the GBA gene have a high likelihood of developing, carrying this, gene, and high likelihood of developing Gaucher's, developing Parkinson's disease. So heterozygous states. So these patients whose family has some, and the association is something I'm not very clear about still, but nonetheless it has been shown. Gaucher's disease family may have, they're harboring this gene, and then there is an association with Parkinson's disease. They come at a younger age of onset, less prominent bradykinesia, rigidity, and tremors, and a high incidence of cognitive impairment. So again, genetics. Now this is just some of the studies individually. You have Park 1 and 4, like I mentioned, this is autosomal dominant, coming at a younger age, and these have a greater association with cognitive decline, and they have a rapid progression. Park 8 again is autosomal dominant. Park 2, this is recessive, and these patients who have the Park 2 gene generally are said to progress a little slowly, and there is a recessive kind of inheritance noticed in these patients. Then you have Park 6 and Park 7, and so on. So this is the genetic story. That's the, we've discussed the environmental story, then the age and the gender, and of course, those factors. Well, protein misfolding is something that happens with alpha-synuclein. Alpha-synuclein is a normal protein found in the nerve cells. But when there is misfolding, then that protein becomes abnormal and starts accumulating in the cells, giving rise and ultimately being seen in the Lewy bodies. So misfolding causes the unfolded alpha-synuclein to self-aggregate. It keeps aggregating and forms ill-soluble molecules. And this is one way in which damage takes place in the normal cells. So protein misfolding is one process that leads to cell toxicity. Neuroinflammation, possibly an important process as far as we know. This is another process that, you see, once patients start to have Parkinson's disease, what is the factor that continues the process over years, as we know? And definitely there are many factors, including genetic, but one of these could be neuroinflammation. Okay, there is microglial activation and increase in astrocytes in the brain cells, and then the extracellular synuclein, which is released, actually it mediates an inflammatory response, and that gives rise to inflammatory cytokines and continues the inflammatory process. So you have degeneration, inflammation, more degeneration, more inflammation, more degeneration, more inflammation, and this is probably what continues the process. Then inflammatory mediators deriving from non-neuronal cells also modulate the progression of neuronal cell death in Parkinson's disease by the neuroinflammatory process. You could have some protective, like NSAIDs possibly could be protective, but this remains to be seen. Mitochondrial dysfunction, we talked about toxins, pesticides. They directly attack the mitochondria and they create cell damage and accelerate mitochondrial apoptosis. Oxidative stress, the release of hydrogen peroxide, superoxide, dismutase, hydroxy radicals, again leading to neurotoxicity. Now, altered alpha-synuclein that I have explained earlier, alpha-synuclein mediates an inflammatory process, and this has been shown in a study 2005, and again it was a study in experimental animals, which was shown that once you have these, release of alpha-synuclein, it mediates an inflammatory response that contributes to the progression of Parkinson's disease eventually. So, in summary, this is what we have in the etiopathogenesis. Although we do not know what exactly causes Parkinson's disease, to be honest, we know a lot about the processes that take place. You have the genetic factors, genetic mutation, alpha-synuclein, and a number of other genes isolated. Then you have the environmental factors. All this leading, to mitochondrial dysfunction. You have oxidative stress, and eventually this leads to cell death and Parkinson's disease. So in summary, although the cause of Parkinson's disease is undetermined, remarkable advances have been made in the understanding of the possible underlying mechanisms. A combination of genetic and environmental factors appear to be at play with, varying with the age of occurrence. The younger the patient, the higher the likelihood that the patient would be having a familial, a genetic component. Older the age, it's possibly idiopathic with possibly some familial genetic component. Then there is an interplay of various processes, like mitochondrial dysfunction, inflammation, oxidative stress, and so on. And alpha-synuclein probably mediates an inflammatory process in the neurons. There may be others also. And this leads to a perpetuation of, cell damage that continues once the disease process has started. This is, in summary, what we know about, and the last 2 decades have been remarkable because last 2 or 3 decades, ever since the advent of MPTP, that was 40 years ago, I think we know a lot, but it's the last 2 decades that have thrown a lot of light on a whole lot of these things, so we know more about it. How it translates eventually into treatment and relief of symptoms and control of the disease remains to be seen. Thank you.
So these slides are courtesy of Dr. Miyazaki and Dr. Raskol, really 2 legends in therapeutic treatment of Parkinson's disease.
So you can use these to change the slides.
Okay, thank you. So it starts the case scenario. A 60-year-old banker presents with a 6-month history of right hand tremor and dragging of right foot when jogging. Physical examination confirms a diagnosis of Parkinson's disease. He meets with clients and executives and finds his tremor interfering with his work. He asks what treatment options are available to him. So it's somewhat typical. The age is somewhat younger. Usually we see 65 and older. 60 will be somewhat younger, but still we'll call it old onset. Before 60, we'll call it young onset PD. I make that distinction because I'm talking about early PD management, and that is different for a young onset PD versus an old onset PD. Most of this data will stick with a classical PD, which is old onset, 65 and above, and I'll explain some changes. Again, it's a tremor predominant disease, as mentioned before. Tremor predominant, which is 70% of PD, the 30% is akinetic rigid, is more classic PD. Dragging of right foot could be from bradykinesia, loss of arm swing on that side, but you have to wonder about right foot dystonia, which is very common, can be an early presentation of Parkinson's disease, and is usually brought on by jogging activity. That also makes me wonder about dystonia on this patient. He meets with clients and executives. That's another important phenomena that doesn't talked about too much. I have patients with similar severity of disease. One want an aggressive control, 100%, 90% control, another is okay with his tremors. And so the treatment is a very personalized, it's very customized treatment. 2 patients with the same severity of disease does not need the same treatment. The goal is just symptom improvement. We're not curing anything. I will briefly go through neuroprotection here about slowing the disease. But everything else is symptom improvement, and symptom improvement is patient guided. They will tell you how much they want improved. But this guy is an executive, so I'm sure he's going for 100% improvement here. So what are the treatment options? So we have a lot of treatment options available. There is still a role of exercise and physiotherapy, and I'll mention that later if it comes up. The question is about always levodopa and dopamine agonists. That's like have been a big debate. Dopamine agonists came out in late 80s, and for 15 years, 20 years, big legends like Anthony Lang from Toronto was always saying that dopamine agonist is the way to go. But we have a lot new information has come up, and it's not really that hard anymore. And so important question is, if levodopa, then how much? When? What is the placement of MAO-B inhibitors? There's some new data which is not in these slides I will share with you guys. So let's look at it. Issues to consider. So really, what we are really looking for is efficacy and safety. If we give the patient a pill, is he going to tolerate it or not? If it's going to have side effects now and in the future, long-term side effects, and will it work or not? And will it work enough for the patient to be satisfied? We also look for things like simplicity, but really that's not a big problem in Parkinson's treatment. Cost can be an issue. However, most of the drugs are now generic, but some generics are still expensive than other generics. Sinemet was discovered in 1951, so you can see how long it has been available. And then there are other issues can be there. A lot of this information is based on this evidence-based review that was initially published in 2002 but updated in 2005 and second update in 2011. But again, that's already 4 years old. There is new data in 4 years. So neuroprotection, let's talk about that. You know, when a patient comes to me, I explain Parkinson to him and I say, okay, the ideal treatment would be a cure. We don't have a cure. The next step would be something that I can give you which will halt the disease or slow it down, so you're still not bothered by it 20 years from now or 30 years from now when you die from the other reason everybody else dies from. But I don't have a neuroprotection. But there are things that came pretty close. A lot of things have been studied. The first trial on neuroprotection, you know, the first reasonable trial on neuroprotection was in 1995, the DataTop study, when they started looking at selegiline, the older MAOB inhibitor, looking for neuroprotection. It was somewhat positive. The problem was the same study was also looking at vitamin E as the neuroprotection, and that was the primary endpoint, not the selegiline. Selegiline was just an add-on. And then vitamin E failed in that trial. A lot of other medications have failed. Some drugs came pretty close, and those two, mainly two of them, are both MAOB inhibitors. The first is selegiline, DataTop study. There was a 5-year study from 95 to 2000, and there was a 8 years follow-up published after that. And there's still positive results from the DataTop study that is coming out. For example, when we go back and look at DataTop patients, what we see is that people who stayed on selegiline after the end of the study, chose to stay on it, are much less likely to develop freezing of gait. Why is that? We don't know. Is it a symptomatic effect of selegiline or is it a neuroprotective effect of selegiline? We don't know, but some information is out there. Rezagiline had many trials. There was the Adagio trial, there was the Presto study, Largo study, a lot of trials looking at neuroprotection by Rezagiline. Initial trials were positive. The final study was Adagio, and now we will look at that quickly. But right now we have no good evidence for any neuroprotection. Almost any drug can be shown to be somewhat neuroprotective because of its symptomatic benefit. You know, you give the patient, their symptoms are better, they look better, you call it, is it neuroprotection? Are they not doing so bad because they're neuroprotected, or their symptoms have improved? So even Levodopa itself, the trial, L-Dopa trial, that was started in 2006, the published results of L-Dopa trial. So in L-Dopa trial, they took 600 patients, 300 were started early on Levodopa, and other 300 were stayed off of Levodopa and then started 6 months later, and then they were followed up. What it showed was that the patients who started Levodopa later on never had similar enough improvement as the people who started early on, 6 months ago. So they never caught up. Is it because Levodopa was neuroprotective, or is it because it has been in the system longer for 6 months, or is it because the washout to check them in Ofsted was only 14 days? There's been a lot of questions, but even L-Dopa has been shown, and even surgery DBS. There is a trial going on in Vanderbilt University right now looking at early DBS in Parkinson. So DBS at 3 to 5 years after the diagnosis of Parkinson. And they're looking at neuroprotection by doing DBS early at 5 years of disease diagnosis. And some people are worried that even that will show a positive response. Then we'll really be stuck because there is no science behind why DBS will be neuroprotective. So that's a very challenging discussion. These words are very important. In the old model of looking for neuroprotection, they used to use concept of time to Levodopa. So if you're neuroprotected, you won't need Levodopa for a while longer. But that was found to be a false way of checking at it. Then they looked at neuroimaging, but that imaging, that was not really helpful. They went to a washout design. You take a medication, then you're washed out for 2 weeks or 1 month, like L-Dopa trial was 2 weeks, and then we look at your off state, complete off state, but that didn't work out. So now the last design that was used by the Adagio study, by the Rezagiline, was a delayed start to see if you start something early, and in some and late in others, if it's neuroprotective, the late group will never catch up to the early group. That was the basic concept on delayed start. But even that could not help Rezagiline get a FDA approval for neuroprotection. So that was the design of Adagio study, a delayed start. You take a medication which is symptomatically better and neuroprotective at the same time. That's the challenge. There is nothing there which is not better for symptomatic, but only neuroprotective. There is a trial going on right now that we're a part of, called the Steady PD study, where we're looking at calcium channel blocker for neuroprotection, which will be different. But this drug, Rezagiline, can improve symptoms. So you give the pill, patient is symptomatically better, then you follow them along with people on placebo. Actually, placebos are also slightly better. So it's not exactly accurate. They also go down little, not as much as the drug. And then they go on, and then at some point, then you start the placebo group also on Rezagiline. And what you have to show is that the slope of these two initial phases, placebo between drug and placebo, is divergent. It's away from each other. It's slower for this one and higher or faster for the placebo group. Then you have to show that when the placebo group take the medication, they never catch up to the early group. Then you have to show that the slopes of the second group between the two groups is at least not convergent, parallel or divergent. And you have to show that at the end point, the two groups never caught up with each other and were never going to caught up even if you continue for the rest of the life. That is a 4-step proof that the drug is neuroprotective and not just symptomatically better. And that is currently probably the only good design we have to look for neuroprotection in Parkinson's disease. So that was the results from Adagio study. They had 1 milligram and 2 milligram dose groups. So there were 3 groups, placebo, 1 milligram and 2 milligram. So patient in 1 milligram completed all these 3 required endpoints. So the slope was slower for the drug patients. You see some improvement with placebo right there, but the slope is faster or steeper. Then they started, they never catch back. The slopes were parallel and they never catch up and they were never convergent. So 1 milligram group showed that resagiline is neuroprotective in that group, but the problem was that the 2 milligram did not show the same. 2 milligram slopes were convergent and it met the first and second endpoint but did not meet the third endpoint, and it cannot be proven beyond doubt that it is neuroprotective. And the other problem was that even if it's neuroprotective, after that 6 months of use or something, the difference, actually at 18 months difference, the difference was very small, 1.7 points on UPDRS scale. UPDRS is Unified Parkinson Disease Rating Scale that we use for assessment of Parkinson's. To give you an idea how small this is, the normal rate of progression of Parkinson's disease, classic Parkinson's disease, is about 5 to 7 points on UPDRS scale in a year, in untreated. In treated one, it can be much slower, or in late stage it could be faster, MSA it's faster, PSP it's extremely fast, but 5 points in a year. So 1.7 points improvement on that 5 points a year at 18 months is really not a lot. Even if it works, it is probably not worthwhile. So that was the Adagio results, and that's why we're now stuck up with no neuroprotective therapy at all. There are 2 trials, one trial going on right now, a large multi-center trial looking at calcium channel inhibitor, and the second one, prindopril, and the second one starting looking at uric acid and protection of Parkinson's, and hopefully in 3 to 5 years we'll be wiser about neuroprotection. So what is left? So in a newly diagnosed patient, if you had a neuroprotective therapy, that would have been the drug of choice. If resagiline is neuroprotective, it's going to save him. He's early in Parkinson's disease, started now. So you can slow him down and he will be good. Because of that partial data on resagiline, many experts still prefer to use resagiline because of the hope of a neuroprotection, although not all of them, because the data is so weak on neuroprotection on resagiline. But if you don't have neuroprotection, then it's symptomatic improvement. Which symptomatic drug? Which all drug works? All drug will improve symptom. But which one? We have to go back to efficacy and, more important, safety profile now and safety profile in 5 years from now. So we know that these drugs are likely efficacious. Bromocriptine, the old one, we never use lyseride. Amantadine, anticholinergics, and ropinirole. We know that these drugs may work, but we don't know enough about them, especially epomorphin. Epomorphin is more of a rescue drug. You have to give it subcutaneously. Starts within 3 to 5 minutes, but only lasts for a half hour to an hour. And then these drugs are not efficacious as a standalone therapy. So monotherapy, we know that they can increase the effectiveness of Sinemet by a short margin, usually 20 to 40 minutes. But they're not efficacious on their own. And there's a long list of drugs that are efficacious. So in efficacy standpoint, there is not a big limitation. You can use almost anything and it will be effective. Actually, you can use a placebo and it will be effective 70% of the time. So it's very easy to treat the symptoms. But just a side point, in terms of efficacy, levodopa is far more effective in symptomatic control as compared to the other drugs. To give you an idea, let me go back to the UPDRS, the Unified Parkinson Disease Rating Scale. Levodopa can improve UPDRS by about 12 to 14 points after starting the therapy with initial doses. 12 to 14 points. So it's a 5-point progression per year. In that sense, it's about almost 2 to 2.5 years of reversal by the levodopa therapy. In comparison, selagiline improves by 6 to 8 points. Resagiline improves by 3 to 5 points. And pramipexole and ropinirole improve by about 5 to 7 points. So medium efficacy in terms of strength or potency, But it doesn't matter a lot in the beginning. You don't need really a shotgun approach unless somebody's an executive and he wants a complete tremor control. Then the best shot you have is levodopa. A small amount will make the tremors go away. So efficacy means a little, not a lot. So that's a trial on efficacy of levodopa, that it is the most efficacious. This is the results from the L-DOPA trial. The patients were divided into 4 groups, and they were taking placebo, 150 milligram levodopa, 300 milligram, and 600 milligram of levodopa, and it was showed that there was a serial benefit. The more you give, the more benefit there is. The maximum improvement was about 14 or 16 points with 600 milligram of levodopa, and actually we showed that after a washout, after taking medication for 6 months, you stop for 2 weeks, you do a washout, the small groups were never as good as the 600 milligram group. So this question about neuroprotection was raised. Another interesting phenomena that we noticed initially in a L-DOPA study and was later found out was the risk of dyskinesia that I will go on to in safety profile. This is a study by Raskol, one of the author of this presentation, on ropinirole plus levodopa supplementation. And again, if you have levodopa to ropinirole in a fully optimized patient. So you have a patient, he's on ropinirole, he's fully optimized, you're getting great response. You add a little bit of levodopa, he gets even better. So even when the ropinirole is working the best, it's not as good as levodopa, but with a small margin. And that only matters later in the disease, may not matter much in the earlier disease. All right, let's look at the more important question on complication. What are we worried about? There are, of course, immediate side effects, and there are long-term side effects. For a long time, we have been worried about the long-term side effects, developing motor complication or dyskinesias, medication-induced dyskinesias. Dyskinesias were unheard of before introduction of Sinemet in 1957 or so. But then it became extremely common. Initially, when the levodopa was started, there was no carbidopa. So in 60s, when Hohen and Yahr were doing their studies and writing Hohen and Yahr staging, they were giving 2 gram, 4 gram, 6 gram, 8 gram of levodopa because there was no carbidopa. And patients were becoming dyskinetic within weeks. Patients were being admitted to the hospital for 4 to 6 weeks, started to start the levodopa therapy, to get rid of the nausea, get them used to levodopa, and by the end of their discharge, they were already developing dyskinesias. So we knew levodopa can cause dyskinesias, and it is medication-induced dyskinesias. So the question is now how not to get dyskinesia. For a long time, we just had Sinemet. Then in 80s, we figured out that amantadine can also work. When we looked at the trials for the flu, and we saw the Sinemet, amantadine was helping tremor in Parkinson patient. Then in late 80s and early 90s, dopamine agonist came out. And when the dopamine agonist came out, the initial studies that were done to prove the efficacy to FDA showed that the group which was on dopamine agonist compared to levodopa patient was having much less dyskinesia. And then suddenly they said, okay, dopamine agonist can prevent dyskinesias. And then they said, well, maybe it can delay the start of dyskinesia. So this is a table that highlights which have a higher risk and lesser risk of developing dyskinesias. So we don't know for sure the risk of dyskinesia with a lot of medication, but we know that if we use dopamine agonists, then we are more likely not to develop dyskinesias early on. Now the new data says that everybody develops dyskinesias. Doesn't matter if you start dopamine agonist or not. So the study that best supports that is a study from UK where they took patients who were not treated for 5 years. For 5 years, patients said, we don't need any treatment, that's okay, we're not bothered by it. So after 5 years of their disease diagnosis, they were started on randomized to dopamine agonists versus MAO-B inhibitors versus Sinemet. And in 6 months, they developed dyskinesias after starting treatment, in 6 months. And the rate was very close, not exactly the same, but very close in levodopa versus dopamine agonist group. So what it showed, what that study suggested was that the development of dyskinesia risk may be more related to the progression of the disease, the lengthening of the disease. What we think about is that there is a bucket over there and it can only hold so much dopamine and the bucket gets shorter and shorter. So when you give dopamine, the bucket is small, there's a lot of spillover, the spillover causes dyskinesias and the bucket runs out early, that's why there's early wearing off. However, there is data now that says that the medication dosage has some association with risk. So the follow-up on